effing hate age limits. Why do women get the age limits? Why do men not get age limits for Viagra or blood pressure medications? Like women get these age, like, oh, 72, right? Like, I don't understand the age limits that society's putting on women for these medications. There's zero age limit for local vaginal hormones. Zero. Start your 91-year-old on it. Hey, everybody. I am trying to go live with Dr. Corinne Menn, and we're having Instagram. Even the Instagram experts just can't some mornings. So we'll see. Here she comes. Awesome, awesome. My cute hoodie that somebody sent me that says Euro on it for urology, because I'm a urologist.
Yay. Okay. Here we are.
I don't know. Your Instagram blocked me.
That's okay. All is well that ends well.
I hope you have the question.
I have all the questions.
Okay.
So, so we're gonna make this like fast fire. So I'm gonna say the question, and we can both you can chime in, I chime in. We're just gonna go through as many as possible. And I just think we're both always really fired up about this. And I just think it's just like appalling. Like we think of this, you and I, as low hanging fruit because we talk a lot about other more complicated uses of hormones. Well, not really complicated, but to the average doctor, it seems complicated. So we think vaginal hormones, this should be easy. But it's still not. We joke. We could just have Instagram accounts where all we do is answer questions about vaginal estrogen, right?
I know, totally. No, I think the like anger is appropriate. I was out to dinner last night, and I'm like, I'm kind of angry today.
Oh, I'm angry.
Yeah, and they're like, "Why are you angry?" And I'm like, "I'm so angry that we know all of this, like
And
that we know all of
fast.
this." Like, and I was like, I got all fired. I'm like, we've been doing this for a very longer than I've been doing it, right? Like medicine's been doing this. We know it's safe. We know it's good, and it's just beating a head against a wall because it's whack-a-mole.
Yeah. And so the reason why I texted you yesterday, and then we'll get into the questions, and what I was saying when you were trying the live earlier was that I saw a patient yesterday who was 10 years from an early stage breast cancer diagnosis, totally doing great. And, is in menopause and has terrible GSM and has not been able to have sex for 2 years. She is literally living your book. You Are Not Broken. Like her and her husband are great communicators. They have an incredible relationship. They just went on a beautiful special trip, just the two of them. And we had the best time, but we weren't able to have sex once because it's so painful. And she just was seen at the Survivorship clinic at a famous world-class breast cancer center, which won't be named, but you could guess. And they recommend coconut oil. And they said, yeah, we just try to avoid estrogen. And Dr. Sadaf, our friend, she just posted something. She had a patient, and Sadaf is also in the New York area, whose, doctor told her to use Crisco. So I think you and I see this, like cooking oils are not GSM treatments. Crisco and coconut oil are not treatments.
Dude, that's an Instagram post.
No, cooking up. I was gonna wait till after this, and then so I figured we come up with some snarky things, but that's my next thread post. Cooking oil is not a prescription for GSM.
And you can link, like we now, the American Urologic Association has published in 2025 GSM guidelines. Nowhere in there is Crisco.
No, Crisco.
Crisco's not a plant.
But coconut oil, it's the same idea of telling people coconut oil. It's a nice moisturizer. You want to moisturize, fine. It is not going to fix your GSM, full stop. Anyways, let's move on to all these questions. All right. So in no particular order, ladies, they're just reading as they come in. So is there a brand with a better applicator that is easy to clean? Not like the ones that I get. Yeah. So I tell patients to ditch the applicator. Thoughts on applicator?
Use your finger.
Use your finger. Don't be afraid of your own body.
I mean, and then when I feel like being snarky, I'm like, we put not clean things in our vaginas, aka partners. Like the applicator is not the dirtiest thing in the world. It's fine. Wash it. Like some people will buy. You can go on Amazon and you can buy a boatload of applicators if you want to destroy the earth and throw a bunch away all the time. So like there's tons of options. Like deal with the applicator and just don't worry about sterility in your vagina because it's not a sterile environment. Number 2, use your finger, which is also not sterile. Number 3, go on Amazon and buy a whole bunch of applicators. But there is, to answer the question specifically, there is not a brand with the best applicator out there.
No, and the other problem with the applicator, because I've used it myself all different ways, right? And the applicator, yes, will deliver the vaginal hormone up into, higher up into the vagina. So if you're concerned about pain and atrophy further up in the vagina, that's great to get it up there, but your finger can get it up there too. But when you put it in, it just leaks out. You wake up in the morning, you've got white vaginal estrogen cream sitting in your underwear and it's messy. And so then people are not compliant with using it. So this is why, and I kind of said it recently on a reel, do we put our face cream on our forehead and hope that it like drips down our face? Oh,
We'd be like, I'm good.
no, we rub our cream in where it needs to go. So rub the cream in upside, up inside and then outside, right?
Yep.
Is it safe during chemotherapy and radiation? Can we use vaginal hormones during cancer treatments?
I think we should use, I mean, people put this thing on their hair so they don't lose their hair. Like it's called pre-treatment, right?
Yes.
Like I do not understand why it's not pre-treatment for women.
Well, so this is a big thing that I totally agree with you. And when I was going through chemotherapy, I was given a whole bunch of prescriptions so that I could tolerate my treatment. I was given medications to keep my white blood cell counts up. I was given anti-nausea medications, anti-anxiety medications, anti-inflammatory medications. I was given prednisone so I could tolerate the therapy. How do do you want your patient to tolerate her treatment? Give her the vaginal hormones up front.
It's a good Substack for you.
It's on my list. I know, but this is interesting. So, like, I don't really understand the idea of giving a medication that you know is going to cause severe estrogen deprivation, not just menopause, but severe deprivation, like an aromatase inhibitor. So everyone understands, making it almost zero. And then saying, and this is our beef with the guidelines. The guidelines, still from the Menopause Society and ACOG, say in breast cancer patients, start with a non-hormonal moisturizer. Again, not a treatment for GSM. And
Do you
then,
start with ginger for nausea or do you go straight to ondansetron?
yeah, or do you start with just like a sling when you have like a hip fracture or something? Or do you go to the actual treatment? So I feel that's a very strange double standard. So yeah, chemotherapy, radiation. And now your thought here, I have very strong feelings about this idea of someone who has very severe atrophy and GSM who was prescribed just twice a week a little dry Vagifem tablet. Nothing against Vagifem for mild or maintenance, but what are your feelings and your experience on that?
Yeah, so that's twice a week is by and large a maintenance dose. If it's the run of the mill average person, I usually don't do a loading dose because I don't like them to have a hormone rush at the beginning because they're super atrophic. They'll get side effects. They won't like it. So I tend to start there just to get them going. And if they're not better in 6 to 8 weeks, you adjust the dose. And I think a lot of women need a lot more hormone than just twice a week. It's very safe. The more you use it, the more risk you have that the dose goes up. But twice a week, and that's all you can do, is a one size fits all that does not fit all.
Yeah, and not just the twice a week, but this idea of when you have severe atrophy and you use a little dry
Oh, the tab.
Vagifem
Oh,
tablet.
yeah. Well,
So
I
to me,
don't
I
do that.
have, yeah, as a gynecologist for years, I would see patients literally for their routine pap smears who were using that. And I would look inside, I was just like, the tablet's not even dissolved because
Right.
the atrophy was so bad that it was a little dry tablet sitting there. And not to say that it doesn't work for some women that works fine. But I think that sometimes we need a little bit more.
Yeah, that's why I love the cream because the cream can get on the vulva. And so if this is the entrance of the vagina, this
Yep.
is the posterior fourchette. And I call it the 6 o'clock spot on a clock. This
Yep.
notoriously gets thinned, tight, pinched, torn. This is pain with insertion right here. And a Vagifem tab up in the vagina does not target this location because it's way up here. And so this is what I tell women: put estrogen cream on it like you're in Texas in August and you're trying not to get sunburned. You want to rub it in.
Yes. I like that analogy. And this is a good one for you, actually. Does vaginal estrogen help to have more fun in sex, like to be more sensitive and feel more? And this
For
kind of
many
brings me
people,
back to what
not for
Rachel Rubin always loves to say is that vaginal estrogen is Viagra for women. So can you just explain that to the audience?
yeah. So estrogen helps these tissues be adult tissues, right?
Yeah.
Like these tissues needed estrogen. They also need androgens and testosterone, and we can get into DHEA, but it helps flexibility of the tissue, like stretching, elasticity, blood flow, which is arousal. In the sex word, blood flow's arousal,
Yep.
right? Nerve sensitivity in a good way, not in a pain way. Right. So, I mean, it's not every woman, but some women, they'll start on vaginal estrogen and they'll be like, my desire's back because sex is great again.
Yeah.
It's like you
And
can
also,
never
this is,
desire pain.
yes, well, I learned this language from your book, which You're Not Broken is something I literally prescribe. It's a prescription for my patients. I tell them, this is your homework, and we're going to follow up in 3 months, and you're going to tell me that you and your partner read it. But
It's
it's a
award
set.
winning now. It won an award. So now I get to say it's award winning.
Love it. Well, I always knew it was award winning. No, but it's literally homework for all of my patients. But this idea that, yeah, your brain will have negative biofeedback if it hurts. Your brain doesn't want to desire something that's causing you harm. And so, yeah, will vaginal estrogen make sex more fun, or you'll be more interested? Yeah, because you'll be interested in something that's not shards of glass. All right. Good one. Does it affect my partner if he comes in contact with it?
I love this question just
I
because
know.
I'm like, we've cared zero for the woman so far, but now let's worry about the penis.
I
Like,
know.
so I get a little snarky because we're like, we're not taking care of you at all. And now you're worried about another person. And it's like the bane of women's problems in society. But we could step back and we can be like, they actually did a study on this. And so a woman put double the dose of a vaginal cream. So very high, 2 grams. 2 grams in her vagina, had penis and vagina intercourse, measured his estradiol levels. Remember, men have estrogen. Men have more estrogen than a postmenopausal woman, right? Their estradiol labs are around 30 to 40. So she puts in a really high dose. They have sex. They measure his labs. They measure his labs 8 hours later, and it raises his labs, but not above normal male estradiol levels. So this is what I tell people. I say, don't use it as a sexual lubricant. We've got lubes for that. But if you happen to put in your vaginal estrogen cream and the moment arises, you don't have to say no. You're not going to hurt anybody.
Yeah. And this is where getting back to the cream and ditching the applicator, I've told women, and I actually use it myself this way. I put my vaginal estrogen cream in the morning. I brush my teeth, my face
Yeah.
cream, and I put
You're
it
a
in the
morning
morning.
person.
Well, because I rub it in with my finger, so there's no messy dripping out. It's already absorbed. So if the mood arises later on, my husband's already at work. I'm not going to do anything with him in the morning. And so then that solves that question if you're really that worried. But I tell women, don't care. I wouldn't worry about it. This is a really, really common one that we always get from patients. Patient who just started vaginal estrogen and she's experiencing itching and irritation, or another common question along this line is that I just started vaginal estrogen and now I got a yeast infection that I never had before. So I have to stop the vaginal estrogen.
Yeah. So vaginal estrogen changes the microbiome of the vagina back to how you were when you had estrogen, right? So it creates more lactobacillus, which then in turn acidify the vagina, and that's how you prevent urinary tract infections. But in doing so, it can disrupt your microbiome and make you more susceptible to a yeast infection. So if
Just
anybody
temporarily, though. Temporarily.
yeah, while you're adjusting your microbiome.
Yeah.
And so, like, when people say, what's the risk of vaginal estrogen? I'm like, rare, but yeast infections for some people. So, what I tell people to do is lower the dose, don't stop, just lower the dose, get treated for the yeast infection. And we're just going to introduce the vaginal estrogen cream more slowly. As you develop a more estrogenized microbiome, the risk of that yeast infection goes away again.
Yeah. Yeah. That's what I see too.
And I would,
And
I would say, and if it's like if you're on an estrogen cream product or something, maybe I'll switch you to the lower dose tabs for a little bit just to like slowly get that microbiome to change. And once you kind of, because women won't trust it then, because they'll be like, it gave me a yeast infection. So like, we got to build back the trust.
yeah.
And once we can build back the trust, then we'll be like, okay, now do you want to go back to the cream? What do you want to do? I have a
Yeah.
lot of women who use the tabs in the vagina and the cream on the vulva.
That was another
So
question that comes up. I do that a lot with my patients too, especially people who I know have a lot of bladder problems and urinary frequency and urgency. And I really want to make sure that they're getting vaginal hormones up inside the vagina, because then that's what gets absorbed into the bladder wall. But they have that pain on the outside. So that's where so there was a bunch of questions about that too. Can we use both? Yes, this is called the art of medicine and being an expert. Like, knowing that you can use not only Vagifem, you can use E-string. Let's remind people the little ring that goes up inside, which is really, really low, steady dose. The medical oncologists actually who get it, like love that because they know it's a very low dose and it's very steady and it really works wonders for women. It's insurance coverage is a problem.
That price will go down. The other thing, just to note on E-string, it's made for 3 months, and a lot of people will say it wears off before then. So I'll have people use E-string for like 2 months, and then they need some cream. So it doesn't always last 3 months for some people. But I like to tell people that because they kind of feel like, they're like, am I crazy that this kind of feels like it's going away after a while? I'm like,
no, you're not crazy. And this is why like having a tube of vaginal estrogen cream is just like a great little add-on if you want to just use it locally and do something on the inside. All right. Most common question that we always hear is that my GYN told me that she will only give me the estrogen patch, not also vaginal estrogen because it's too much estrogen. Or the patch is going to totally treat my GSM. Bullocks, nonsense. That's not true. At least 50% of women need vaginal hormones.
yeah,
Comments?
I see it all the time. I just want to address, somebody had put a femring price in there. Femring, systemic hormones. We're not talking about systemic hormones. We're talking about estring, which is the local ring. So there's 2 vaginal rings, femring, estring. We're talking about estring because we're talking about local pelvic hormones right now. Yeah, so this is my math equation, and I'm like, I'm sorry for anybody who listens to me a lot and effing hates my math equation at this point. But if systemic hormones patch raises your estradiol levels to X, and pelvic hormones raise your estradiol 0, X plus 0 is X, meaning you can be on a patch and vaginal estrogen and not raise your hormone levels. Somebody was like, I was at a Ishwish conference like last year. They're like, you need to do a study proving that. And I'm like, we have a million studies showing that low dose vaginal estrogen doesn't raise hormone levels. We already have the studies. That's why I have this equation, right? Like we don't need more. This is one area where we don't need more research.
No, yeah, it's maddening. The other thing that this is again where I kind of push back on, I still think the guidelines are too conservative when it comes to this and this idea of like, well, a woman presents with menopausal symptoms, hot flashes, night sweats, and some GSM symptoms. And you say, well, let's start with the patch and progesterone, say, and then if it doesn't help in 3 or 4 months, then we could start the vaginal hormones. I'm like, no, she has the symptoms both. Treat her. Why are you perpetuating and prolonging suffering? I don't get it.
Wasn't that just a question in like the endocrine boards or something?
Dr. Salas Whalen, right? I think it was Rocio.
Yeah.
She said in her endocrine boards, the question was for a breast cancer survivor who presents with hot flashes and painful sex. And it gave the option. You can only pick one. And Vioza or Fezolineate was the answer, which then is we'll come back to general vaginal estrogen questions, but we're going to get heavy into the breast cancer questions because there's such extreme suffering in this community. So the first one is, and it's funny, this is the second, I had my own patient come to me with this question. This came up in our thread yesterday. A pharmacist would not prescribe or would not dispense the vaginal estrogen to me because I'm on Vioza. And so the thing is, when you put so this is a thing that people don't realize. So when you prescribe Vioza and you try to put an estrogen prescription in, not systemic estrogen, but a local vaginal estrogen, it flags in the pharmacy system because systemic estrogen has a potential to potentiate the impact of Vioza's impact on the liver. We know Vioza, Fezolineate, has a warning about
oral systemic
estrogen. Again, this is where class labeling of estrogens causes harm. So this is the second question I've had where a breast cancer patient on Vioza and it's effectively treating her hot flashes is now being told by either a doctor or her pharmacist that she can't take vaginal estrogen because in the pharmacy system, she gets a red flag. Yeah, and so totally not true. Vioza, Fezolineate, you absolutely can use that along with vaginal hormones.
Dr. Menn, is there a medication with which you cannot use a vaginal hormone product?
No.
I can't think of one.
There's none. So, yeah. And so just to because there's a bunch of random questions about other medical contraindications outside of the breast cancer stuff, which we're going to dig into in a second. But literally, I don't care if you're 80 and had a stroke, a massive heart attack. I don't care if you have some complicated autoimmune disease. I mean, I care about those things. but I don't care about them when it comes to vaginal estrogen. Do you feel
Yeah.
the same?
Yeah. Oh, I agree. Especially since there's nothing that decreases urinary tract infections more successfully than a healthy vagina and a well estronized vagina, aka vaginal estrogen. And these women, these frail women with medical comorbidities, they're at the highest risk of hospitalization, sepsis, and death from urinary tract infections. Why would you not treat them? And I think that before we get into the breast cancer stuff, just to dispel the myth that there's an age limit, I effing hate age limits. Why do women get the age limits? Why do men not get age limits for Viagra or blood pressure medication?
No,
Women get these age, like, oh, 72, right?
no.
Like, I don't understand the age limits that society's putting on women for these medications. So there's zero age limit for local vaginal hormones. Zero. Start your 91-year-old on it.
Yeah, and for all the ladies listening, you probably have an aunt, a grandmother, a mom, or a friend who is older, who might be elderly. This is an uncomfortable conversation to have with them sometimes. They don't want to bring it up, vaginal pain, dryness, and even if they're not sexually active, because people write off older, elderly women or women in a nursing home saying, oh, well, she's not having sex. Why would she need vaginal estrogen? Well, first of all, a lot of nursing home patients are having sex, just so you know. And it should be pleasurable for them if they want it. But it's because of urosepsis, UTIs, the risks of going to the emergency room with a urinary tract infection, right?
Yeah.
That's just why we should want our elderly women in our lives to have access to vaginal hormones.
Yeah, and you have to explain to man, I have, and not to stereotype generation, but I have a lot of older women. They don't understand that their vagina is theirs and it's theirs to take care of, and it can actually help them reduce the. I'll say vaginal estrogen for UTIs, and they'll be like, "But my husband's dead." And so
Yeah.
it's like you do have to educate people that
Yeah,
like
they don't know.
vaginal health is bladder health, is pelvic health, and it's all related.
Yeah, yeah, absolutely. I actually had a friend's mom, chronic UTIs, not on vaginal estrogen, getting up every night to go to the bathroom, elderly, and she fell and she broke her hip. So I actually think vaginal estrogen would have prevented her hip fracture.
Yeah, I mean the
I
number.
mean, it's literally that serious.
Vaginal
Um,
estrogen is as good as anticholinergics for overactive bladder. So getting up at night to pee, huge risk of falls, urinary incontinence, the number one reason people end up in a nursing home, right? So these aren't small problems. And
no,
people be like, I get to sleep through the night or only get up one time to pee now instead of 4 or 5, which they just thought was normal, not realizing that this is a low hormone problem. The bladder gets spastic when it has low hormones. The trigone muscle of the bladder gets spastic. We've got the studies. So you put the hormones back, the bladder can function better.
yeah, yeah, totally. So let's get into the breast cancer patients and the suffering. So I'm just going to read these things. Breast cancer survivor. I was told not to use the estrogen on the inside. Sex is excruciating, and I've avoided it for 5 years. So let's bust the myth that vaginal hormone should not be used on the inside of the canal in breast cancer survivors. So I hear this a lot. They're finally beg, barter, and steal. They get this prescription, and then they're told by the survivorship NP or the medical oncologist or the ill-informed GYN to put a dot, a pea-sized amount, and just rub it a little bit on the outside. And I'm thinking, and that's one thing they're told. The other thing they're told is, you can use it for 6 weeks, just for a short period of time. It like literally makes no sense, right?
Right.
So
Yeah.
this
And
is
you have to
not a
explain that to people because they think a tube is the treatment course instead
yes.
of this. You will go back to how you were when the hormones
Yes.
go away.
Yeah. So there is no data to say that breast cancer patients should only be using it on the outside. Correct, Kelly?
Correct.
Yes. Okay. Here, let's go. Here, I want to try to like lump some of these. All right. So let's just talk about um tamoxifen and aromatase inhibitors. All right. So is vaginal estrogen safe for women who are on ovarian suppression or already menopausal and are using tamoxifen? Let's say it together, Kelly. Yes. Yes. So, and it's really interesting. Tamoxifen impact on the vaginal canal, the outside of the tissues, is different than the impact on with an aromatase inhibitor. Tamoxifen itself doesn't cause severe vaginal atrophy in premenopausal women, but it can cause like irritation and inflammation. But once you're menopausal, it can accelerate those changes, but not to the degree as an aromatase inhibitor. Why don't you explain to people what an aromatase inhibitor means to vaginal tissue and what's the degree of estrogen deprivation, Kelly?
Yeah, so aromatase inhibitors, and correct me if I'm wrong, but so aromatase inhibitors, our bodies make testosterone. Testosterone converts to estrogen, estradiol, because of the aromatase enzyme. That's the machine that takes our testosterone and makes it estrogen. So when you put an aromatase inhibitor in, your estrogen levels plummet because now there's no machine making any estradiol because you blocked that machine. In that the genitals become adult because of testosterone and estrogen. And so you're really going down to very, very low levels of estrogen.
Yeah. And so this is the case that, like we were referring to before, that when we know we're going to be initiating medications like aromatase inhibitors, and these women are not on them for just a few months, they're on them for generally 5 to 10 years. This is severe deprivation of hormones everywhere. Our conversation is not about that. We're talking literally about the local effect of these hormones. And we have no studies that show an increase in mortality or recurrence with these low dose local vaginal hormone products, even if you are using aromatase inhibitors.
Well, there's the Dutch study, which caused the big kerfuffle.
The Danish study, the Danes and the Dutch, they always get themselves mixed up.
They
I have like a huge beef with that. To me, the Danish study is like the WHI. It's like it's this ridiculous. Well, no, the WHI was a ridiculous study.
talk about it. That's the study that says
That's
you
the
can't
study.
use it. So we should talk about that study.
So let's get what's really interesting about that study is, and it was published fairly recently, about like 3 or 4 years ago, and it is literally held up as, well, but if you're on an aromatase inhibitor, we have this study. But actually it's kind of like your point about the WHI. The doctors who are using that study to deny vaginal hormones to people on aromatase inhibitors, actually, I don't think they ever read the study.
Yeah, you say why, and they'll add to it if it's
And so a couple of things. So what was really interesting in that study, number one, the study was, these are retrospective reviews, right? So these studies were looking back, and interesting in the study, one of the big points were only women who were at the most high risk of having breast cancer recurrence were being put on aromatase inhibitors. Basically, the practice patterns in that study were not modern day practice patterns. Basically, just a subset, a minority of the survived or breast cancer patients were being given aromatase inhibitors. So already the group who were being given aromatase inhibitors were already by definition at a higher risk of having recurrence. And it's basically not modern practice, meaning like basically low and high risk patients now are all put on them. So this study already was setting up the patients who were on aromatase inhibitors to already have a higher risk of recurrence, number one. They were using much higher levels of vaginal estrogen than what we do in contemporary practice, right? So those were the two kind of biggest points of why the data is not actually applicable to modern practice. And they actually showed no increased risk of mortality either. To the point where Sherry Goldfarb, who is a medical breast oncologist at Memorial Sloan Kettering, along with other leaders from the Menopause Society, actually issued a rebuttal and a practice statement from the Menopause Society that Danish study should not be used to deny breast cancer survivors who are on aromatase inhibitors access to vaginal hormones, and it should not be practice changing. They actually published that in the Journal of Clinical Oncology, and the Menopause Society made it a practice alert to go out to all of their members. But that's something that nobody ever brings up with these patients.
Love that. And isn't it also true that breast cancer survivors in this study who are on systemic hormones didn't have any increased risk of recurrence?
Yeah,
That's the other big red flag is like, how is it biologically possible that the vaginal estrogen would, but the systemic ones wouldn't?
Yeah, there's so many flaws with the study. And so the problem is that if you're going to deny patients access to a medication that can be life-changing, life-saving, and you don't really know the details of why you're denying it, then you have no business to be advising that patient, right? You can't just tell patients no, and you can't really back up why you're saying no. So I think, I don't know, today or tomorrow, I'll put up a link to that, to the rebuttal that Dr. Goldfarb, who is a breast medical oncologist, highly respected, wrote. So we'll give the details. So let's talk about how we can, because it's a huge problem. The women on aromatase inhibitors, it's increasingly more common that more and more women are being put on these aromatase inhibitors. So I have my ideal cocktail of like what I would use for these women, but would like to kind of hear, and do you have any thoughts about that before I kind of give them a spiel?
Yeah, I mean,
Vaginal
to
hormones.
me, I'm like, first of all, I'm concerned that the informed consent is not there. Many, many, many. I don't know if I've heard a woman say, they told me what's going to happen when I take this aromatase inhibitor. So I think first and foremost, if informed consent's not there, I would like to add that to the toolkit of like, this is how this medication works. As a consequence of how this medication works, this is what you might experience.
Yes.
Because you might experience these things, this is what we're going to do to help you. Like, to me, I'm like, I did not just ask to go to the moon right there. I told you what standard medical practice should be.
Yeah.
That's what we should do with any medication. So certainly vaginal estrogen, low-hanging fruit, vaginal estradiol creams, the cheapest. I think some women do a lot better with DHEA, especially if we're talking like profound GSM. Because
well, I'm glad you brought it up. That's very, very important because, and what's interesting is, so quickly, let's just explain to people that vaginal DHA is a FDA approved option. The brand name is Intrarosa. And interesting, in my experience with medical oncologists, they actually are more comfortable with DHA because it doesn't say the word estrogen in it, even though the way it works is that it within the cells gets converted to estrogen and to testosterone.
It doesn't work on the DHEA receptors. It works on the testosterone and estrogen receptors.
Yeah, and this is not.
But it doesn't have the box warning. They didn't.
It doesn't.
And they didn't even put the box warning on.
Yeah, so I think it's interesting. The medical oncology community seems to like that, which is fine. I love Intrarosa and DHA. So to me, if I have a patient on an aromatase inhibitor, and I know that their GSM is going to either be profound or it already is profound, I often will lean in onto Intrarosa. When you have a very nervous medical oncologist who's very reluctant to prescribe it, Dr. Alison Macbeth in the UK, she actually just wrote a post this morning, and I think she was smart by saying this. In Europe, estriol is the standard kind of their FDA approved version of vaginal hormones. Estriol does not convert to estradiol. It doesn't convert to estradiol.
Yeah.
Estriol is extremely weak on breast tissue. So if you have a very nervous patient and a very nervous medical oncologist, compounding in the US, an estriol vaginal cream, which you can get if you're really nervous about it. Again, I don't think this is absolutely necessary, but it's an option for women who are facing barriers. A vaginal estriol cream can be prepared in a really nice, like a Versa base or non-irritating base. And that can be, kind of like a bridge to getting women access. And I also, if people are also really nervous, Imvexi, the brand Imvexi, which is an estradiol insert, does come in a lower 4 microgram versus a 10 microgram.
Doesn't work. It's because it's very, very low dose and you might think different.
So the only reason I bring the estriol and the very low dose Imvexi is to give women another tool to be able to communicate with their medical oncologist to just get rid over some of the fear and the psychological barriers. We are not saying you need to use these absolute lower doses, lower potency options, but they're a bridge, right?
Yeah. Yeah. Yeah, yeah. We're experts and we know a lot, which can be confusing to people, but it can also be that's where the gems are that can really help a lot of people.
Yes.
One thing I want to make sure we hit is if you're on local vaginal estrogen only, do you need to be on a progesterone because of that? See that all the time.
Absolutely not. You don't need progesterone. And we had multiple questions come in about that. Actually, I'm looking one right here. I'm on vaginal estrogen 3 times a week. If I use less than 3 times a week, I still suffer. My new doctor I saw said that that's way too much. And now I have to take a progesterone to protect my uterus. So like, this is just nonsensical. So this comes back to individualization. Not every woman does great with it twice a week. Many, many women need it 3 times a week, 5 times a week. This is low dose. It's okay. I tell patients, titrate, use it as frequently as you need to treat your symptoms.
And here's the secret, but like a pro tip is if you're using it more than that, you do need a prescription for that amount, because otherwise the pharmacist will not refill your tube early. They're sticklers on this stuff. Like, it's actually harmful in many countries, by the way. So it's very safe. If you don't have the prescription written for every other day and you run out of it early, you can't get a refill if it's only written for 2 times a week. So that's like a tip and trick.
Yes. And a patient wrote that today saying that her PA will only write it for twice a week and her copay is very high for it. And so she's having all these increased costs. So that's just crazy nonsense. Okay. GYN cancers, endometrial cancer, ovarian cancer, vaginal hormones are safe, right, Kelly?
Yes, I will asterisk very rare uterine sarcoma, which is a very rare. It's not your normal bread and butter endometrial adenocarcinoma. Mm-hmm. Very rare uterine sarcoma. It's like there's like case studies or something like that you can't. So the true experts will know, like, that's the one thing, but it's so incredibly rare that it's it's a longer conversation versus like, dude, by and large, everybody can be on vaginal estrogen.
Yeah. Also, other hormonal conditions that people think about hormones with: endometriosis. Vaginal estrogen is safe. Systemic estrogen is also safe.
Vaginal estrogen when you're breastfeeding.
Well, that's the genitourinary syndrome of lactation, because breastfeeding causes lower hormone levels, lower estrogen levels, right? And so a lot of women have painful sex while they're breastfeeding. Very safe. With more and more women living with metastatic breast cancer years ago was considered a death sentence. Now, many, many women are living with metastatic breast cancer as it being a chronic disease for them. And they, luckily we're blessed with more and more treatments for advanced breast cancer. But I see the metastatic breast cancer community of younger women in particular are really, really ignored, that because they have metastatic cancer, they're like, well, no, like, you're going to have to just give up on your sex life. We can't even give you vaginal hormones. There is no data that tells us that metastatic breast cancer patients can't also use low-dose vaginal hormones. These women are often on hormone blockers for the rest of their lives because they're metastatic disease. But again, we're using hormones that don't raise systemic hormone levels.
Yeah. Yes, and exactly. And I would add, caring about the woman's quality of life has completely gone out the door. Relationships end over this. Like, it's painful to pee. Like, recurrent UTIs end up in a hospital. Like, to not care about her quality of life over, especially when we don't have any data that you're going to make anything worse with it. Like, it's so myopic.
You could just measure an estrogen. If you're really that worried, just freaking order an estrogen level. I don't recommend people getting their estrogen levels checked when they're taking vaginal hormones alone. But if you're in some complicated medical situation, you've got a fearful medical oncologist. This patient wrote, one of the questions was, I have metastatic breast cancer and I'm on Ibrance and Faslodex with recurrent UTIs. So someone who is being treated for chronic UTIs and also has cancer, we don't want their immune system to be challenged by recurrent infections. That puts them at risk for other complications. Yep. So to me, the last person, I would never want a cancer patient to have recurrent UTIs. So just for that reason alone, right?
Yep. Yeah, it's awful.
It's awful. This is an interesting, I got a question from a woman who's a DES daughter. So maternal DES exposure. She has an increased risk herself of clear cell adenocarcinoma of the vagina and cervix. And her doctor refuses to give her vaginal estrogen. There is no data that DES children, patients, adult women should not have vaginal estrogen.
Yeah.
You don't need
well, it's apples and oranges. This is a synthetic medication that has lots of risks. Nobody uses it anymore. And we're talking about low dose estradiol, which is what your body naturally makes. And this is like the brilliant Corinne Menn, who's always like, was removing your ovaries a treatment plan for you being a DES daughter? Right? Yeah. Because your ovaries made estradiol. And if the answer is no, which the answer is no, why can't you give yourself a little bit of skincare that has estradiol in it? And I love that logic question. Like, it's the best thing ever because it really makes people think like, oh, I'm scared of something that my ovaries been giving me for 40 years.
Yeah. So yeah, and this is like the triple negative breast cancer. All breast cancer patients can use hormone therapy or local vaginal hormone therapy, but for these triple negative breast cancer patient, she has her breast cancer. She goes through her chemotherapy. Her periods come back to normal. She has 7 years of normal hormone production. Removing her ovaries was not part of her treatment plan. Lowering her estrogen wasn't. And then she gets her to menopause either because it naturally happens, or maybe she carries a BRCA mutation and she wants to lower her ovarian cancer risk. So then she has her ovaries taken out for that reason, not to lower her hormone levels for cancer. And then she's denied vaginal hormones or even a discussion on systemic. It's like, sometimes I think this knee-jerk reaction is not the practice of medicine. It's like the doctors are giving advice and they're not even reading the literature.
Yeah. Yeah. It's pretty flip.
It's pretty much.
I have to go take the kids to school. So could we do like one or two more questions?
Yeah, I think I'm going to end it with something that is just like, I'll just read the last one. My 75-year-old woman mother is having recurrent UTIs. She requested vaginal estrogen and her doc did not even consider it, saying she's far too old to start it now.
That's the age shit I keep telling you about. Like, once you see that we're using a woman's age as a marker for, where does it say in anything that a woman becomes too old for something? We don't say that to men. We give 90-year-olds Viagra, for the love of God. Like, they're human also. Like, there's my Instagram post for the day. It's like 72-year-olds are also humans. It's insane. So if you have trouble getting vaginal hormones from your doctor and you know it's safe and you have a legitimate access problem, this is where the online hormone menopause companies are great. Intralude is one that only does vaginal estrogen. You can use the code not broken for a discount on there. Alloy, Evernow, Genev, Midi. What am I missing? There's a lot of online companies now that do hormones. So know that that's an option.
The other point there is that you do not need permission from your medical oncologist. I'm going to just say this boldly. You don't need permission. They are not the ruler of your life to get a vaginal hormone. Okay. And so this is a huge problem. And so I see sometimes some doctors require the oncologist to sign off on it. I will push back on that. I think you should always inform your medical team of what you're doing. Your oncologist should be aware. But if you want to pursue this and your sexual medicine expert, your menopause doctor, whether it's an online physician or your in-person doctor, is going to write the prescription for vaginal estrogen, they should not be blocked because your medical oncologist doesn't know the literature and is not up to date.
Yeah, I mean, I'll just go there because I'll go there. But alcohol is really bad and is associated with 8 cancers. Do you call your oncologist every time you take a drink? Right. And that's like way more risky than vaginal estrogen.
So Kelly, do they ask us permission to prescribe aromatase inhibitors to make sure that we're okay with the collateral damages of decades of estrogen deprivation? Do we get permission? No.
You should get an informed consent.
But you should get an informed consent, and that's not happening. Okay, now we're feeling spicy. Okay.
This is so great. I think what I will do is I'm able to pull this audio and we'll keep it up on Instagram so everybody can refer your sister and your mother to this, but I'll also probably try to pull the audio and put it on the podcast later on this fall so that more people can get this knowledge because this was on fire good.
Yep. Love it. Love you. Have fun with bringing your kids to school. Have a great day.
Love you. Till next time.